maternal mortality here in Virginia. Maternal death review teams have been around in Virginia since about 1928. Back then, it was a collaboration between the Medical Society of Virginia and the Virginia Department of Health. And those early reviews mainly focused on medical issues and natural deaths. Due to a lack of funding during the 1990s, those maternal reviews declined. And that was also during a time where there was an increase in, maternal mortality overall. Throughout the 1900s, maternal mortality rate had decreased significantly due to asepsis protocols were instituted. There was a shift from home births to hospital deliveries. There were also institutional practice guidelines and guidelines defining physician qualifications related to hospital privileges. Those were also implemented. Use of antibiotics and safer blood transfusions, as well as better management and monitoring of hypertensive conditions. In the early 2002, the maternal mortality team here was reestablished due to a call from the CDC because of the increase in maternal mortality rates that we were seeing nationwide. And this iteration of the maternal mortality review team came about as a partnership within the Virginia Department of Health between the Office of Family Health Services and the Office of the Chief Medical Examiner. Funding for the project is through Title V, and it established a statewide multidisciplinary review team that also included violent deaths. So that's all accidentals, murders, homicides, as well as the natural causes of death. And the reviews from this team are conducted in the spirit of public health and with the purpose of injury and death prevention. Our current team includes representation from the Virginia chapters of the American College of Nurse Midwives, the American College of Obstetricians and Gynecologists, National Association of Social Workers, the Association of Women's Health, Obstetric and Neonatal Nurses, and the Virginia College of Emergency Room Physicians. We also have representatives from Family Health Services and the Office of the Chief Medical Examiner and Women and Infants Health and the Department of Health, as well as membership from the Medical Society of Virginia, the Virginia Hospital and Healthcare Association, the Virginia Sexual and Domestic Violence Action Alliance, the Academy of Nutrition and Dietetics, the Department of Behavioral Health and Developmental Services, as well as the Department of Social Services and the Department of Medical Assistance Services. And we also have representatives from the disciplines of pharmacy and psychiatry on the team as well. The team's purpose is to essentially understand the causes of maternal deaths and to educate colleagues and policymakers about these deaths and the issues that we are finding in the data and the needs for changes in practice as well as policy. And we also make recommendations for improvement and prevention. As our team, we review all pregnancy-associated deaths, and that would be the death of any woman that dies within a year of the termination of pregnancy. That's regardless of the cause of death or regardless of the outcome of the pregnancy. We identify cases through several ways. One of the first ways would be the ICD-10 code on the death certificate. That would be the O codes or all the obstetric-related codes. We also do a cross-matching of vital records with the fetal death certificate or birth certificate cross-matched with the maternal death certificate. We also have the death certificate checkbox, which just recently was changed to include 365 days after the woman's death. And we also have some cases that are identified through the Virginia Violent Death Registry. Those cases are typically be cases where there's a miscarriage or an abortion that may not otherwise be indicated on the death certificate. In preparation for our case review, we obtain records from the Office of Health Statistics. They provide us with the death certificates and the birth certificates. And from there, we kind of begin our record collection with the hospital where the death occurred, where the birth occurred, and the birth attended. We kind of work backwards and start from there to find all the records and all the information that we can for the last 5 years of that woman's life, at least those last 5 years. The team coordinator will then create a case summary. The case summary is de-identified narrative summary. It includes all medical, surgical, and psychiatric history we were able to find. Also discusses the family history, social history, the obstetrical history, any prenatal care records that they have, delivery, the events of the death, and it also includes pathological, toxicological findings, and also any law enforcement or DSS involved. There are three primary questions that we asked during the review. The first would be, was the death pregnancy related? And a pregnancy related death would be the death of a woman within 1 year of the termination of pregnancy that was due to a pregnancy complication, a chain of events initiated by the pregnancy, or the aggravation of an unrelated condition by the physiological effects of the pregnancy. We then asked, was this death preventable? And we also look at what factors could have contributed to the death and what reasonable changes could have been made to alter the outcome for this one. When we look at preventability, a preventable death is defined as a death that may have been averted by one or more changes in clinical care, facility infrastructure, the community, or a system's response to patient factors. These determinations are made with the benefit of retrospective review and current clinical practice guidelines. Throughout the reviews of these cases, we look at these cases to identify risk factors, and once we complete a year of case review, we kind of aggregate all that data and present it to the team. And this review consists of a narrative description of all the characteristics of all the cases, aggregate data on the factors determined to have contributed to the deaths, and qualitative list of ideas for prevention and intervention generated from all the cases reviewed. And we use this information to develop topics for our next team report, so that all the reports that come out of our team are topic specific to issues that arise from the data that we reviewed. This aggregate data is then used to try to help establish priorities and program funding. And one of the most important parts about the fact that we're reviewing all pregnancy-associated deaths is that it gives us a chance to look at the health of women of childbearing age in general. One of the things that we find is that the trends and patterns that we see among these women are the same trends and patterns that we see among women of childbearing age in general. So as the opioid use increased among childbearing age in general, we saw that opioid use increase amongst our maternal deaths as well. This brings us to our most recent report, which will be coming out in mid-February. And that report is on chronic disease in pregnancy and associated deaths in Virginia from 1999 to 2002. This report goes up to 2002 because, as we said, with the retrospective case review, there's a lag in between the time we were able to review cases, and when the women have actually died. And so what we've done as a team is collectively decided to move forward, and we're currently working on our 2015 cases so that we can be more current and more relevant to the current issues that are taking place now. So the purpose of this chronic disease report was essentially to examine the prevalence of chronic diseases and comorbidities in cases of pregnancy-associated deaths, to identify the gaps in the coordination of care received by pregnant women during prenatal care, perinatal care, and the postpartum period, and to identify areas in which improvements can be made in the management and coordination of care of diseases for pregnant women. And to conduct this report, we had to create chronic disease categories. These chronic disease categories include things like cardiovascular diseases, which are your congestive heart failures, heart disease, heart palpitations, hypertension. We also have chronic infectious diseases, such as HIV/AIDS. We also include chronic mental illness, as well as chronic substance abuse, collagen vascular diseases, such as fibromyalgia, scleroderma, Sjogren's syndrome. We also have endocrine disorders. Under endocrine disorders, we also included morbid obesity, diabetes, Graves' disease, hypothyroidism, and polycystic ovaries disease. We have gastrointestinal diseases such as cholelithiasis, Crohn's disease, chronic abdominal pain, hepatitis C, and irritable bowel syndrome, as well as genital diseases such as endometriosis, endometritis, uterine fibroids. We also have hematologic malignancies, lymphocytic leukemia, the anaplastic large cells lymphomas, and anemia, clotting disorders, Hodgkin's lymphomas. We also included neoplasias, followed by neuromuscular diseases such as amyotrophic lateral sclerosis, Bell's palsy. We included general chronic pain under this category as well, epilepsy, and chronic migraines or headaches. And then we have pulmonary diseases, which include asthma, pulmonary fibrosis, and sarcoidosis, as well as urinary diseases such as chronic kidney disease, pulmonary disease, and polycystic kidney disease. Overall, we found that there were some demographic differences between women with a chronic disease and women without a chronic disease. The maternal mortality ratios were significantly higher among women with a chronic disease. For both groups, white women died more frequently. However, the maternal mortality ratio for black women was always significantly higher. Among women without a chronic disease, that ratio was almost 3 times higher. Among black women and among women with a chronic disease, the ratio was almost twice as high. Over 42% of those with a chronic condition are age 30 and older, compared to just about 28% of those without a chronic disease. And the Eastern Health Plan region had the highest maternal mortality ratios for both groups. The maternal mortality ratio for women with a chronic disease in the Eastern Health Plan region was over twice as high for women without a chronic disease as it was for those with it. And over half of the women with the chronic condition were on Medicaid, or 6% at, 45% on Medicaid and about 6% were self-pay. We also found distinct differences in key pregnancy risk factors for women with chronic diseases. Prenatal care utilization amongst these groups were similar for both groups, were with those without a chronic disease and having slightly more inadequate prenatal care, and that simply was based on the number of prenatal care visits determined by when they started prenatal care. Women with a chronic condition also had more substance use during pregnancy. They were more likely to have tobacco use, alcohol use, or some other substance use documented in their records. And they also had other high rate of other risk factors, such as history of domestic violence and being treated for depression within a year prior to their death. Women with a chronic condition also tend to have more complications in previous pregnancy, such as gestational diabetes or other pregnancy-related complications. When looking at the prevalence of chronic diseases, we found that there were 848 cases of chronic diseases and 427. We had, by this time, we had reviewed about 628 cases of deaths, and 427 of those cases had at least one chronic condition. The prevalence of chronic conditions would range from one condition to cases where there were up to 7 conditions, and there were certain patterns that could be found in there. So it was not unusual to have a woman with diabetes who was also hypertensive and had chronic depression. So I'm trying to tend to see certain things that kind of went hand in hand. The most prevalent was endocrine disorders, diabetes and obesity, being amongst the most prevalent conditions there, followed by chronic mental illness and chronic substance abuse. About 30% of these women had chronic substance abuse identified in their medical records. We had about 44% with an endocrine disorder and about 36% with chronic mental illness. The least prevalent were collagen vascular diseases, chronic infectious diseases, and urinary diseases. Among women with a chronic disease, this is by chronic disease category, overall the average of age was between 27 to 30 for each chronic disease category. Women with a cardiovascular disease had a high percentage of advanced maternal age. 35% of those women were aged 35 and older. Black women were the most common race for cases with infectious diseases, hematologic malignancies, pulmonary diseases, and urinary diseases. The Eastern Health Plan region had the highest percentage of cardiovascular diseases, endocrine disorders, gastrointestinal diseases, hematologic malignancies, neoplasias, neuromuscular diseases, and pulmonary diseases. The Central Health Plan region had the highest percentage of infectious diseases, chronic mental illness, substance abuse, and urinary diseases. Women with collagen vascular diseases hematologic malignancies, neoplasias, urinary diseases had a higher percentage with private insurance, whereas women with chronic mental illness, substance abuse, neuromuscular disease, pulmonary diseases were more likely to have Medicaid. And looking at the manner and causes of death amongst women with chronic disease categories, the most common manner of death for women of all categories, with the exception of chronic substance abuse, was a natural death. So overall, when all causes were considered, most women died from natural causes, except when you're looking at chronic substance abuse, it means women were more likely to die from accidental deaths, be it a motor vehicle accident, an accidental overdose, or some other type of accident. Cardiac disorder was the most common cause of death for women with cardiovascular diseases, collagen vascular diseases, endocrine disorders, gastrointestinal diseases, hematologic malignancies, and urinary diseases. Accidental overdose was the most common cause of death for women with a chronic mental illness, neuromuscular disease, pulmonary diseases, and chronic substance abuse. The chronic disease was found to contribute to the death of over 50% of women with chronic cardiovascular disease, and infectious disease, chronic substance abuse, collagen vascular disease, or neoplasia. And over 50% of women with a cardiovascular disease, endocrine disorder, hematologic malignancy, or pulmonary disease were obese. And nearly 5% of women with a cardiovascular disease, or 7% of women with an endocrine disorder were considered supermorbid obese, which is a BMI greater than or equal to 50. We explored the contributors to mortality. And when we're looking at contributors to mortality, we look at facility-related factors, community factors, as well as provider factors and patient factors. For this report, we focused on facility factors, community factors, and provider factors. And overall, for the 502 cases that the team was able to review, we had at least one facility factor contribute to the death of a woman in 15% of all of our cases.